Hello, my name is William Young. I am the statewide vice president of the North Carolina Public Service Workers Union, UE Local 150. I work as an inventory assistant at Cherry Hospital in Goldsboro, North Carolina. Welcome to our forum tonight titled Aetna Exposed, Statewide Teaching and Campaign Launch. Out of this meeting tonight, our union, UE 150, is launching an important new campaign titled Workers' Health, Not Corporate Wealth. A little housekeeping before we get started. Everyone, please mute your lines so we can all hear the speakers. We will have time for questions and answers at the end of the program. You are also welcome to post questions and comments in the chat during the presentations. On the agenda tonight, we will hear from a few frontline workers in various public sector jobs, from state mental health DHHS workers, workers in the UNC system, city workers, and public education teachers. We appreciate the North Carolina Association of Educators joining us tonight for this important discussion. After a few of our workers speak, we will hear two very exciting speakers tonight, who I will introduce shortly. Then we will hear a few more workers speak. A union member, Charles Owens, will be giving the union presentation towards the end. Then we will have call to action and questions. During tonight's meeting, you will learn why is North Carolina the most expensive place on earth for healthcare? Two, who really owns Aetna, and why are large corporations, corporate healthcare companies making record profits while workers suffer? Tonight's presentation is focused on state workers, local city government workers, and education workers. But fundamentally, the current healthcare crisis is our state impacts all workers. As many of you know, UE 150 has been very active this year, pushing back against the major attacks on the state health plan. Many workers were upset last year when the state first transitioned from Blue Cross Blue Shield to Aetna. Many workers were forced to leave their doctors that they have been seeing for years to see others that were in network. About a year ago, the state treasurer, Brad Briner, announced that the state health plan had a $507 million budget shortfall for, for the 2026. UE 150 launched into serious action and formed a state health plan committee. Many of us attended several of the state health plan board of trustees meeting this spring, launched the campaign, met privately with several state health plan members, and also Brad Biner and his staff to push back against the idea that workers alone should be covering the majority of the budget gap, especially when we don't have a raise. As folks may know, the state legislature still has not passed the budget, but the state treasurer had to balance his budget and implement his cuts. Through our fight this year, we were able to secure $150 million in additional funding on top of what the state paid last year for the health plan, yet still left $357 million on state workers and teachers to pay for. This has resulted in record increase in our premiums, co-pays, and deductibles this year. We are currently in open enrollment, and many workers are getting sticker shock from how much more we are being forced to pay. The average state worker and teacher will face a payout this year of $1,206 due to the price increase of our insurance. This is unacceptable and why we are organizing. In addition to the terrible increase we face now, next year the state health plan is facing an additional $800 million budget gap. We can't let them balance that budget on the backs of workers. On tonight's meeting, you will also learn how you can get involved and how to fight back. If you have ideas of actions we can take at your workplace or across the state, we also encourage you to post those ideas in the chat. Now we are going to hear from two frontline workers. First up, we have Ashley West, a social worker from Central Regional.
Good evening, everybody. My name's Ashley. I'm a clinical social worker at Central Regional Hospital. I've been a state employee for approximately 21 years. My healthcare costs are going to be tripling in the coming year. With the increased premiums alone, I'll be spending almost $1,000 out of my paycheck. At this time next year, for prescriptions alone, I will have to pay $2,000 out of pocket. Currently, I'm at $650. That's unacceptable. I have chronic health conditions. I've been a state employee for nearly 21 years. I shouldn't have to bear the brunt of the budget shortfall, just like my friends and colleagues. No one should have to deal with this, given that corporations are making so much money off of us. You'll hear more about that tonight. Thank you so much for joining us. I'm so glad to have you all here.
You're muted, William.
Thank you, Ashley. Next up, we have Michael Pearson. He works in the water department from the city of Greensboro.
I'm Michael Pearson from the city of Greensboro, North Carolina. I work at the Water Resources Department. Right now, we are basically going through what a lot of you guys are going through with this 7% increase on our healthcare. They're basically making us jump through hoops and rings just to even get anything going. We're not getting a pay raise for anything. We're not getting any merit raises or anything like that. We're getting a 4% cost of living raise, but we're also in a city debt right now, and our city council understands that it's been this way for years and has done nothing about it. So I'm here on behalf of my city and also UE 150 Greensboro to, show our support and see what we can do, and hopefully we'll get something happening out here. And peace to everybody that's here. Thank you for having me.
That was great. I am now excited to announce our first guest speaker. Dr. Kerry Willis is a former State Health Plan Board of Trustees member who was the most loudest voice on the board early this year when our union was pushing back against the price increases. Willis spoke out at several meetings about the CARES Act money that the state received that should have been diverted to help state health plan, but instead was put to other political priorities. He has also spoke publicly about the obscene reimbursement rates that private healthcare corporations are charging workers and the state health plan for their care. He has long advocated for a cap on reimbursement rates and will speak to these issues. Due to his strong advocacy this spring, he was removed from the State Health Plan Board of Trustees by Senator Bergen himself. Dr. Willis, take it away.
You're muted, Dr. Willis.
Thank you very much for that kind introduction. I appreciate the invitation to come and speak. Healthcare costs and expenses is one of the things that's kind of near and dear to my heart. Not only for state employees, but for all of my patients. I mean, we get to live in North Carolina, which is kind of a wonderful place to live. But in terms of healthcare expense, it's among one of the most expensive places in the nation to obtain healthcare benefits. There's a recent study published out of Yale that said that our hospitals currently are being reimbursed somewhere between 350 and 400% of Medicare for their services. Most places, they're happy at 200 or less percent of Medicare, and we're paying 3 to 4 times more than that. The strain on the state health plan budget because of that pricing is tremendous. We spend far more on sick care, if you will, at hospitals than we spend in primary care services to prevent and treat chronic diseases. We only spend about 4% of the healthcare budget in North Carolina for primary care and preventative medicine purposes. We might want to look at that spending and figure out another strategy we could use to be a lot healthier than we are. But looking at pharma and the expenses there, looking at PBMs or pharmacy benefit managers, which are other private corporations that act as middlemen and have mainly served to run up the cost of medicine. And then we come to the hospital expense, which is mainly not for profit, by the way. It's not a for-profit venture. But they seem to be in cahoots with the for-profit ventures that seem to be sucking money out of the state and the federal treasuries. Looking specifically at the state health plan, I think it's important to understand the numbers and understand what got us in the hole that we're in. During COVID from 2018 through 2020, the state health plan had a little over $500 million worth of expense for treating COVID. The legislature gave them about a little more than $200 million, leaving a deficit of $300 million from COVID alone. There was also an unfunded deficit of $200 million that the plan requested, but was not funded and given by the legislature. That expense continued to be incurred. The previous treasurer, Dale Falwell, took some money out of reserves and some other areas and used to cover that money rather than increasing premiums. And that's all been, those numbers are confirmed by the state auditor who did a spot audit and confirmed that the problem was $300 million in unfunded COVID money and $200 million in basically unfunded deficit that was incurred. Now, the big thing that I think everyone needs to know about the COVID expense was that the CARES Act at the federal level provided about $2 billion to the state of North Carolina. That money could have and was partially used to reimburse the COVID expense. It should have been used to reimburse the entire COVID expense. Instead, like most of the COVID money, it got shuttled from agency to agency to agency to agency, and then it eventually was declared unused and put back into the unused fund. The state with the governor, with Cooper, with the consent of the House and the Senate, both controlled by Republicans at the time, went back to the federal government and asked for permission to repurpose that money, which was granted. So basically, instead of using it to pay the bills that we'd already incurred and the bills for necessary expense, that money was squandered and used on pork barrel projects by both parties. It was a very bipartisan squandering of funds, if you will. Apparently, it's one of the few things they agreed on that year. That, however, resulted in the state health plan having the huge deficit that it had that was predicted for this year, resulting in the changes in the premiums, in the deductibles, the copays, the out-of-pocket expense, and all the other changes that were made. Unfortunately for the state health plan, it has no choice in the way it funds things. The amount of reserve that is required to be able to pay claims is set by statute. They're not allowed to go below that point. After using up some of the reserve funds, they were close and towing the line on the point where they would be unable to pay claims in a reasonable manner. So that resulted in the plans to increase the copays, deductibles, premiums, out-of-pocket expense, and all the other things. If you have any significant amount of healthcare expense, if you're in and out of the hospital during the year, you're going to have a significant increase in your out-of-pocket money that you're going to owe compared to previous years with the plan. They have no other choice but do that. They have to balance their books at the end of the day, and they have to provide that money. But let me be real clear on something. There is some discussion and thought that the problem with the deficit was because of the clear pricing program. The clear pricing program provided a minimal level of benefit to any provider who was not contracted or who was contracted with the state. Many organizations, mostly hospitals that run outpatient facilities, Duke, Atrium, UNC, contracted directly on their own. They were not part of the clear pricing program. Clear pricing program was mostly independent physicians and providers in both primary care and in specialties. They were being contracted far below Medicare at rates that were, basically below their cost of being seen. The act by Treasurer Falwell allowed those rates to increase to about 160% of Medicare. So when they say the Clear Pricing Act caused the problem, that's untrue. When you're only 4% of the spending, a 15-20% increase in spending on 4% becomes a rounding error in the budget. It's not real, it's not big, and it's not certainly causing much of the problem. You got to look at the real places where you're spending excessively, and that's in hospital rates and in pharma. They're taking steps trying to address all that, but I think we need to take a good long look at hospital finances as well. For those of you who don't know, Medicaid expansion resulted in a windfall for the hospitals. All the charity care, for the most part, that they'd been giving away was now covered because of people who were able to get coverage because of the Medicaid expansion. That benefited primarily large hospitals. It benefited some of the rural hospitals. But the big benefit was not just in the money that they got from the Medicaid coverage. The big benefit was in a group of funds that were called HASP funds, HASP. That resulted in $10 billion in funds, 80% of which went to the 8 largest hospitals in North Carolina, all of which were already wildly profitable. So most of the HAS money went right straight to the bottom line and provided large bonuses for executives in healthcare because they were already making money at the time. I think if anything, when we look at the current political environment, when we look at hospitals, when we look at all the folks who are saying, oh, we're losing money on there's a lot of folks losing money that seem to be building great big steel and glass buildings, in my opinion. But I think the biggest problem in healthcare right now is that margin has come before mission. We've forgotten that we had to put people first, that providing healthcare to them has to be our primary goals. And that if we're doing that, we're doing it properly, margin will be there if we're taking care of mission first. But we can't put money first and forget our people and be able to take care of them properly. And I'm just going to close at that point, and thank you for having me and extending me the invitation. But I did want to touch base on one more thing. You were talking about the state budget that's held up right now. It's being held up because of the Senate wanting to spend $300 million on a new children's hospital that's being proposed by Duke and UNC currently. That will be a 500-bed facility. It's already gotten $100 million in funding from the legislature already. That's where your money's going instead of going to fund the state employees' state health plan. To build a hospital that I really have great questions about whether we even need it. And I'm probably going to upset somebody by saying that. But we don't usually have a census of 500 children in the hospital in North Carolina on any given day. And building yet another children's hospital in addition to the existing children's hospitals that are already there, I'm struggling very hard to understand the need or the reason for it if we can't pay for basic health benefits for our state employees. But those are the things that are being made priorities. Those are the issues that are coming up. And if you understand the numbers, where the money's being spent, where the money came from, where the money got shifted to, it's a lot easier to argue and discuss it with these folks than it is if you don't know the numbers. But the purpose of knowing the numbers is to be able to take care of people. For the last 40 years, I've practiced medicine in Eastern North Carolina. I have seen whoever walked through the doors. I didn't worry about what kind of insurance they had, and our practice has flourished, and I've made a good living. And we've been a good part of the community and taking care of them. I'm proof that you can put mission in front of margin and still do well. And I think we just need to take a good long look at our priorities, where we spend our money, making sure that we're getting our dollars worth for the money we spend, and making sure that we put people first, that mission has to be the primary purpose of healthcare before margin. And I'm done.
Thank you. That was powerful. Thanks again, Dr. Willis. We look forward to working with you to get this healthcare crisis back under control. Now we will hear from a few more frontline workers. Do we have Teresa Pelosi? No. Okay. What about Robin Lee? All right. Well, we're going to move on. All right. We are excited to be joined by our second guest speaker, Dr. Connie Morrison, MD, who is a member of the North Carolina Medicare of All Coalition and president of the Physicians for a National Health Plan chapter in North Carolina and an employee of the UNC Health System. She will be speaking about why this moment commands us to be demanding a universal single payer system at the state and federal level. Our union is a long supporter of Medicare for all. She will also speak on the downfalls of privatizing retiree health care and Medicare Advantage plans. Thanks for being here, Dr. Morrison.
Thank you so much. And just to introduce Dr. Elaine Green, who will be joining me as well. She's our Vice President for NC Healthcare for All and a retired obstetrician gynecologist and was a big activist voice for Medicaid expansion in North Carolina. So I'm really happy to have her join me for part of this as well. Let me just get my slideshow up. I really want to echo what Dr. Willis said about people first and mission ahead of margin. I think we wholly agree that that's where healthcare should be. And so I'm a primary care doctor here in Central North Carolina. I work in Chapel Hill and I also work in the hospital. And of course, my views represent myself, not UNC. And Elaine, do you want to just say hi real quick?
Hello, I'm Dr. Eleanor Elaine Wilson Green, and I'm Vice President of NC Healthcare for All. And I'll speak primarily on the traditional Medicare versus Medicare Advantage.
And I just wanted to add one thing to what Dr. Willis was mentioning about in terms of why the budget hasn't come to an agreement on the state level. I do think it's smart that we're thinking about all the things that the legislature is funding, including like a new hospital, which is a huge expense, obviously. But the other disagreement, I think, is over whether to extend corporate tax cuts. And so part of the reason we don't have the funds that we need is that North Carolina keeps voting to give corporations tax cuts. And so that really diminishes the revenue that the state raises. And so the Republicans have recognized that. And the House has said, maybe we ought to pause the tax cuts at 2.5%. And the Senate said, oh, we want to keep going down to 0%. So as the law has originally been passed. And so there's a disagreement between the two houses about raising money that could go towards healthcare. And so I do think that's also when we're talking about priorities, is our priority to give tax cuts to these huge corporations, or is it to fund the state health plan? And it's a big it's a question of those priorities. So I'm here to talk primarily about Medicare for All, which is what Healthcare for All NC advocates for, and what I wish we had instead of our system that currently doesn't really work for anyone. So as a doctor, I see every day that our current system is broken. It's not working well for our patients. It's not really working well for me either. As a doctor, having to navigate all these insurances and everything while often having to think about cost and what my patients can actually access. And we see this in the data too. We spend the most as a country compared to all the other big economies around the world, and we have the worst health outcomes compared to these other countries. We're the only country in the world where people go bankrupt due to illness. And there's major disparities in outcomes based on race and socioeconomic status. We do have amazing healthcare in the US, like we can provide it, but unfortunately only some people are getting it. And so you're seeing people, poor people and people from different backgrounds who can't access that excellent care that we should all have access to. And then our system is primarily built around employer-based plans, which, as union members, y'all have a voice to fight that and to advocate with your employers about what the plans can be, but many people don't have that voice. And even you guys are seeing now with the state health plan change that you're just stuck with whatever your employer chooses for you. And so if you need healthcare, then you can't leave a bad job. And if you're in a good job that you want to keep and they change to a bad healthcare plan, then you're stuck with a bad healthcare plan. And additionally, there's the issue of even having health insurance in the US, but many more Americans are underinsured, where, as y'all have put in the comments, we have insurance, but it's just not paying for nearly enough. And so healthcare still feels pretty unattainable and too expensive. It's getting worse, unfortunately, right now. HR 1 was the federal budget that passed in the spring, also called the Big Beautiful Bill. And unfortunately, it's going to result in 10 million Americans without health insurance. In North Carolina, that's going to be a 4% increase, about 450,000 people who previously had insurance through Medicaid primarily, and other means who will no longer have it. And now in the shutdown, we're seeing this disagreement between extending subsidies for the Obamacare plans. One side says no subsidies, they're going to go away at the new year, and the other side is asking them to be extended because the costs are just going to shoot way up. And so because of those costs shooting up, if things stay how they are now, another 4 million Americans are going to lose access to their health insurance. So unfortunately, things are getting worse. And that's why we're advocating that, healthcare should be a public good, something that the government funds and is free to its citizens at the point of service, just like the fire department, public libraries, public schools. These are all things that we raise money for through taxes. And then when we go to access them, we don't have to, spend an arm and a leg just to get a basic service. And just like Dr. Willis mentioned, we feel at Healthcare for All that the doctor-patient relationship is a service. It's not a commercial transaction. It's me wanting to help folks in my community and help keep them healthy. And similarly, users of healthcare services are patients. I don't think about the people I see as consumers or clients or all these things that we've made them in corporate healthcare. So what we want at Healthcare for All NC is Medicare for all. And that's not just simply taking Medicare as it is now and expanding it to everyone, but it's with improvements. Medicare for all is the government guaranteeing comprehensive health insurance to all Americans under a single publicly funded, publicly accountable plan. So it would be universal coverage for everyone. There would be better negotiating power, which would allow prices to be much more well-controlled than they are now. It would be efficient, so the costs to administer it would be a lot less. Right now, private insurance companies incur 5 times greater costs than our public plans. And additionally, just thinking about it as a doctor, like I wouldn't have to guess like what health insurance is my patient on. I would actually know like how much something is going to cost and whether a patient can access it instead of trying to navigate this like maze of different plans. The financing would be progressive, so people who make lower income would pay less relative to their income, so it would save particularly lower income folks a lot of money. And it would have the same public accountability and public investment that we put into other public goods. What it is not is socialized medicine. You hear that a lot, but it doesn't make doctors and hospitals the government. They don't work for the government. They're still private and they remain private. The government just provides the health insurance that funds it. And consumers would still get to choose where and from whom they wish to receive care. And it's not simply just expanding Medicare in its current form. We know that Medicare in its current form has a lot of good things, but it has a lot of challenges as well. And right now it's so complicated. There's multiple plans for hospital care, for outpatient care, for medications, and we need to simplify it if we're going to implement this. It would have minimal or no out-of-pocket costs, and it would need to include things like dental, vision, hearing, things that right now are unfortunately left out of most Medicare plans. And this would allow the private for-profit Medicare Advantage to be eliminated, which Elaine will talk about more in just a minute. How will it help? We know it would improve health outcomes. More people having insurance means more people get preventive care, that the family doctor care that prevents them from getting cancer instead of having to wait till they're sick and needing hospital care. And it would give that access to everyone, regardless of their income or background. So it would just be better for more people. And there would be better value for that care. Our government wouldn't be paying as much because we would be able to negotiate to limit price increases. There would be less administrative costs and a lot less administrators to give bonuses to. And no one denying services to make a profit, which unfortunately happens now a lot under for-profit health plans where, you know, I tell my patient that they need an inhaler for their lungs and then they go to try to get it, but because the inhaler is expensive, their insurance says, I'm not going to pay for it. And then they can't get the basic care that they need. So the main question people ask is, how do you pay for this? It sounds expensive, right? Well, the way we do this is we take the money that's already being spent. There's already a lot of public money in healthcare, and then we're all paying a ton in premiums, co-pays, deductibles, co-insurance, all the things y'all have been shouting out in the chat, like $300 for an ER visit. When you combine all that money and instead of making each person pay it when they go use a service, instead you collect it as taxes and you use it to pay for the care up front. You use that money more effectively. And through the ways I've already mentioned, the goal is also to lower those expenses so we don't have to use as much money on healthcare. So everybody gets healthcare and the overall spending is lower. And this has been shown by nonpartisan budget analyses that the cost would be, we could take all the money that we're already paying and we could get a better healthcare system with it. And 95% of people will pay less for healthcare than they do now. The bottom line for Medicare for All is that the majority of households would save money, especially lower income folks. American taxpayers would save a lot of money, $650 billion annually as projected by the Congressional Budget Office. And more Americans would live longer with better quality of life because they'll be actually getting health care. And I just want to shout out the Medicare for All Act. It's been introduced in the House and the Senate this year, as it has been many years. And this is kind of the improved Medicare for All vision. So it takes Medicare that exists currently and tries to make it better so that it actually meets Americans' needs, including dental care, mental health care, hearing aids, which I know has been like excluded for way too long, vision, more home health and long-term care. And includes limiting costs from drug companies and really limits out-of-pocket costs and covers all Americans from birth to death. All right, so I'm going to turn it over to Elaine now just to talk a little bit about traditional Medicare versus Medicare Advantage, because that's something we're seeing a lot, that we're dealing with a lot in the current health insurance landscape.
Hello?
We can hear
Connie,
you.
Thank you. Thank you so much for that presentation. It was excellent. I'm going to talk to you about traditional Medicare versus Medicare Advantage, which we call disadvantage. And you'll see why once you hear what I have to say. Just a quick review. Medicare is a federal insurance program for individuals aged 65 and older, as well as certain younger people with medical conditions or disabilities. Traditional or original Medicare consists of Part A and Part B. Part A covers inpatient hospital care, short-term skilled nursing facilities, hospital care, and some home health services. Part B covers doctor visits, ambulance services, and durable medical equipment. Traditional Medicare pays 80% of covered healthcare costs, and the individual pays the other 20%. It generally does not cover many prescription drugs, vision, dental, hearing services, long-term nursing, or home health care. So many choose to buy an additional insurance called Medigap, a supplement, to cover that 20%. You have the option to purchase the supplemental or Medigap plan and or a prescription drug plans, which is Part D, when enrolling into Medicare. So if you think you want those plans, you should sign up then, because both have penalties for signing up late. Approximately 20 years ago, Medicare Advantage was designed as an alternative to traditional Medicare to provide innovative ways of delivering health care at a lower cost. Unfortunately, these claims have not been realized. When Medicare Advantage plans are marketed to seniors, they seem wonderful. Low cost, comprehensive coverage, perks, etc. However, they do not market the fact that plans are associated with increased prior authorization requirements and denials, which create barriers and delays to receiving care. Medicare Advantage plans can also deny care that would be covered on traditional Medicare. Often seniors are unaware that insurance brokers are paid incentives to enroll them into a Medicare Advantage plan as opposed to signing them up for traditional Medicare with a supplement. So when it's time to sign up for Medicare, an alternative is to work with the Senior Health Insurance Program, or SHP, which is funded by the government. They do not get paid extra for just steering you toward a particular plan. Since Medicare Advantage's inception, legislation that has been passed has been favorable to Medicare Advantage, and thus the enrollment has been more than doubled since 2010 to 54% of all Medicare beneficiaries, and that number is projected to grow. This favorable legislation has contributed to Medicare Advantage's evolution into a system where profits often take precedence over patients. But there have been recent efforts to limit this, as shown by the Department of Justice's criminal investigation into United Health's business practices. The private insurance industry claims that Medicare Advantage plans save government money, but the Independent Medicare Payment Advisory Commission, or MedPAC, has found the opposite. In its March 2025 report, MedPAC estimated that Medicare Advantage plans will cost the federal government $84 billion more in 2025 alone than if those same beneficiaries were enrolled in traditional fee-for-service Medicare. These excess costs are driven mainly by two factors: upcoding and cherry picking. Cherry picking is enrolling healthier individuals whose costs are lower, and upcoding is done also. The government pays Medicare Advantage plans more for high-risk patients, so companies upcode to make enrollees appear sicker to increase payments and profits. Also, Medicare Advantage's overhead is 18%, while traditional Medicare's overhead is 2%. These excessive overhead costs contribute to the industry charging the government more. MedPAC's analysis and other independent experts show that these overpayments have ranged from about $80 billion to as high as $140 billion per year. And there is no evidence that Medicare Advantage plans produce better quality health outcomes. While not all Medicare Advantage plans are problematic, care must be made in choosing a plan. If you truly cannot afford traditional Medicare, Medicare Advantage may be attractive to you. However, be aware that if you become ill, you may have a problem getting the care that you feel that you need, when you need it, and where you need it, because you signed on to a Medicare Advantage plan which limits your choice. They may have a limited panel of providers that you choose not to go to, but you have no choice, or to face penalties, because unfortunately, if you find yourself in a predicament like this, you may not be able to switch back to a traditional Medicare plan without the significant penalties if the time has elapsed. So these are a lot of things that people don't think about. You know, saving the money up front sounds good, but just don't get sick, because if you do, it can be very difficult for you.
Thank you so much, Elaine. So we just want to end with inviting y'all to join us in the fight for single payer healthcare. We want healthcare that's high quality, comprehensive, universal, publicly funded, publicly accountable, equitable, and affordable for all Americans. Thank you all so much.
All right, thank y'all both for that presentation. We will now be led by Charles Owens, a healthcare worker at Cherry Hospital, and he is also the vice president of Cherry Oberry chapter of UE 150.
Excuse me. Good evening, everybody. I hope everybody can hear me. I'm Charles Owens. I want to thank you all for joining us and hopefully joining in on this fight. I'm a healthcare technician at Cherry Hospital in Goldsboro, one of the state's 3 DHHS psychiatric facilities. I'm also the vice president of the Cherry Oberry chapter of UE 150. A couple of quick points about me. I'm retired military, and most folks will say I'm a little outspoken. And if I seem a little militant, I do apologize because I'm very passionate about the things I believe in. And this is one of the things that I truly, truly believe in. Before I get started, I want to make one acknowledgement. I see that our chapter president, Mr. Willie Brown, is here. Thank you for coming in. We appreciate you. And my participation in this event is twofold. One, educate, give you some of the facts and stuff that we need to know, that you need to know. And two, hopefully motivate and fire you up to get started in this program, participate in this whole battle, and hopefully get some of your friends to join. All right. As William stated, we hope to expose the private healthcare corporations' profit motive that is behind many of the high-priced healthcare, not only for state workers, city workers, and teachers, but for all working people across North Carolina. Who really owns Aetna? You ever stop to think about that? Well, here's something that should be no surprise. CVS owns Aetna. CVS, the largest pharmacy operator in the US. CVS Health Group is the world's second largest healthcare corporation. CVS was focused on reversing course by lowering health insurance benefits, increasing plan prices, and exiting certain markets, meaning this stuff they're going to cut out, they're not going to cover. CVS makes money on drugs while Aetna loses money pushing up drug prices, undercutting independent pharmacies, and driving up overall state health plan costs. Now, you ask stuff, why have CVS, Amazon, and Walgreens invested billions of dollars to acquire enterprises that reliably lose hundreds of millions of dollars per year? What do the world's largest retailers, the truly consumer-centric companies, know that the rest of the health economy doesn't know? In one word, pharmacy. So essentially, while state employees are sitting here, have no raises this year, and our healthcare options are getting cut, CVS is raking in the dough. CVS is forecasting 2025 full year revenues of at least $391.5 billion, an increase of approximately $9 billion, driven by increases across all segments. Second quarter total revenues increased to $98.9 billion, up 8.4% compared to the prior year. The company's healthcare benefits segment reported revenues of $36 billion, up nearly 12% year over year. CVS Health and Services segment, which includes its pharmacy, benefited Management Solutions section reported total revenues increased 10.2%, up to $46 billion. CVS plans to exit Obamacare in 2026. That's definitely their plan. Why not? The Republicans are trying to cut it anyway, so why not get out of it ahead of time? This affects 1 million Aetna members as the Donald Trump White House and Republicans in Congress ponder cuts to health insurance benefits to pay for their tax cuts for the wealthy. It's like that's why the government shut down now. Why is North Carolina the most expensive state in the country for healthcare? And by extension, the most expensive place on earth for healthcare? One, high hospital price markups. The cost of healthcare in North Carolina is the most expensive in the country, and by extension, in the world. Healthcare corporations are flocking to North Carolina and buying up local small health providers and increasingly monopolizing the market to rake in record profits. Those of you that live here in Goldsboro, you know that's one of the reasons why the little pharmacy on Wayne Memorial closed down. Somebody bought them up. This past year, Atrium and Duke and others were in high-profile negotiations that yielded higher reimbursement rates, which means higher prices for the patients to line their pockets. As Dr. Willis discussed, there's no cap on reimbursement rates set by this legislature. Charge whatever they want. Certain providers in North Carolina are allowed to charge any amount they want for their services. And North Carolina law requires the insurer to pay it. That's why Aetna loses money. This drives up the cost by $40 billion a year nationally. If hospitals can survive with the rate set by the federal government for Medicare, why are hospitals allowed to change the state health plan 600% of Medicare rates for the same procedures? This is price gouging. One of the things we want, we demand a cap on reimbursement rates set by the state legislature. North Carolina healthcare spending per capita comes out at $8,917 annually, while nationally, the average is $10,191. So we're paying almost $2,000 more in this state than the rest of the nation. Number two, North Carolina bosses shift higher portions of insurance costs onto the workers. We ought to know, it just happened to us. North Carolina is the lowest union rate in the country, meaning workers have the least amount of power to negotiate and more coverage, well, least amount of power to negotiate coverage from their employees. Please, slip of the tongue, dry mouth a little bit. North and South Carolina are the only states in the country where collective bargaining, a union contract for public workers, is explicitly illegal. You can look it up. It says in big bold letters, prohibited. This dates back to an old Jim Crow era law that was passed in 1959, and it's still on the books, which is what they're using to maintain that status. We need collective bargaining rights. The hospital and major corporations are able to bargain the rate to raise their prices. So why can't the workers bargain to raise our wages and get safer working conditions? Everybody that knows me knows that my mental, from the time in April when we started talking to Mr. Briner about this whole healthcare plan issue, from that point started working towards collective bargaining. Anybody's been involved or even paying attention to the news with the Duke Aetna deal, with the state Aetna deal, you can realize simple, they all negotiated to get what they wanted or what they needed. Mr. Briner said to us, those of us workers that were there in front of his face, and I believe the teachers union were there too. He said, we haven't raised you guys premiums or deductibles in 8 years. So it's time you guys put some of the bill. I'm sorry. That's a load of crap. They didn't do it because they were able to budget it in and cover it. So why can't they do it now? And if you look or paid attention to the Duke Aetna deal, Duke said the same thing to Aetna. We haven't asked for an increase in 4 years. Y'all need to pay us a little bit more. And Mr. Briner came out and said, they're trying to get more money off the backs of the workers. Well, dude, ain't that what you just did? The exact same thing. And Aetna undercut Blue Cross Blue Shield to get the state contract in the first place. Did. Ask any female that's going to get a mammogram during her annual health care check. I'm sorry, I digress. Let me get back to where I'm supposed to be. Hospital mergers and buyouts of small local independent providers. Many of the local small doctors, offices, and clinics are getting bought up around the state by the larger healthcare corporations. The most notable was when Healthcare Corporation of America bought out purchased the Mission Health System, including the hospital in Asheville. The sale of the nonprofit hospital system was a subject of controversy and legal scrutiny. The recent reports suggest potential negative impacts on services and staffing, despite the significant increase in profits for HCA. The recent hospital consolidation in North Carolina includes Duke Health acquiring Lake Norman Regional Medical Center in April of this year, Novant Health acquiring Lake Norman Regional and Davis Regional Medical Center in a $320 million deal that was approved last year. Other recent consolidations include Advent Health acquiring St. Luke's Hospital in Columbus, and larger systems like Atrium Health and HCA Healthcare continuing their expansion through mergers and acquisitions in and around this state. Now, let's chat a little bit about some of these CEOs and their high salaries. One of these corporations, Atrium, gave top executives pay increases of an average of 41% last year. Meanwhile, state employees still ain't got no raise schedule, and if we're lucky, we might get 2 to 4%. They getting 10 times what we even thinking about or praying for. This impacts all of our members, whether state, municipal, or private sector. Novant CEO Carl Amato received 9.6% raise in 2023. His base salary went from 2.3 million. Oh, I'm sorry, 2.03. Let's not give more money than you already had, right? 2.03 million to 2.26 million, bringing his total compensation to 5.82 million. This increase was driven by a rise in his incentive pay, which grew by 19%. Now, you'll see on this chart that across the board, CEO pay for the big hospitals in North Carolina is way too high. These bonuses are eating all the cake and ain't leaving none of us the crumbs. We can't even get a crumb. Just pick out a number or two on the screen and look at it. This is what these folks is getting, and we can't even get 4%. Pop quiz. DHHS Dr. Sangwal, where many of us on this meeting work, where did he work before he came to DHHS? You ever stop to think about it? Well, here's the answer. He was the president of Duke Regional Hospital. And before that, the president of the North Carolina Medical Society. So do you really think he took a pay cut to come here? I don't think so. But in closing, I'm gonna say anybody that's got their video on and can see me right about now, you can look back there. That's my retirement plaque and all that. And I stated right from the beginning, I'm retired military. This has I'm sorry. Oh, okay. Can you still hear me? I'm sorry.
We can hear you.
Okay, with the fact that I'm retired military, I'm in the VA. I don't pay these premiums and deductibles, and I'm in this fight. I'm in this fight simply because they're wrong, and they're doing wrong. I joined the military to stand up for folks that can't stand up for themselves, to fight overseas so that my children don't have to fight. I joined this fight for the people that work at Cherry Hospital, that are worried about losing their jobs, that are working too hard to make ends meet. I say to those of you that are not in the fight, why aren't you here? Where are you? I challenge you to join this fight. One voice can be heard. 3 voices can be ignored. 100, 1,000, 10,000, you can't stop them. And you have to listen. I'm politically minded, and I say to you all, pay attention to who's in office in the legislature. Local elections are next week. Federal elections are next year. It's never too early to start working towards that. I thank you all for your time. I hope I can motivate somebody, and I hope I drop some knowledge on you. Mr. Brown, I hope we did you proud. Thank you, ladies and gentlemen, for your time.
You did, Charles. Wonderful job. Thanks for that powerful information, Charles. Definitely makes me fired up to want to fight against these healthcare corporations. We are not just gathered here to learn. While that is important, we must also take actions. We need to go down and talk to these legislators and let them know why we need collective bargaining. We need to rally. We don't need to just sit back and do nothing. You know, there's strength in numbers, and the more people get involved, the more we can get stuff done. Go back and educate some of your coworkers that may not know what's going on. Get them involved. Participate in some of these rallies. Don't balance budget on backs of workers. Fully fund state health plan. Cap on reimbursement rates. State level single payer expanded and improve Medicare for all. Collective bargaining rights. Corporations and wealthy pay fair share of taxes. Right now we came to the part, do we have any questions? If you have any questions, you can unmute yourself. No questions?
This is Nikhil here. I have a question. So what's our next step? How do we build off this?
If I can take that, William,
Yes, go ahead.
that right there, that's on the screen right now. We're having an organizing meeting Thursday, November 6th at 6 o'clock on Zoom. Join in, give us your ideas, help us figure out what we can do, what our next step is. Thanks.
This is Yolanda. I work at Caswell in Kinston. I was part of the UE 150 I worked at Cherry Hospital. Charles, I think you remember me. I'm still trying to figure out how certain medications that I was on when I worked at Cherry when we had Blue Cross Blue Shield to now Aetna don't even pay for the same medication that they did pay for. I'm still trying to understand that situation.
Yeah, Yolanda, I mean, I think that's a really good question. And I saw Etta Austin Burgess also put a similar comment. You know, in this fight with the treasurer, with Brad Briner, you know, he's been claiming that in the transition from Blue Cross Blue Shield to Aetna, that the state, that the coverage is the same, that all the same services should be covered. Of course, that's not been the reality for thousands of workers. And so one of the things we're doing in the union and with your help is gathering those stories. So if that's happening to you, Yolanda, if that's happening to you, Sister Etta, we want you to help collect documentation on what those changes were, um, and identify what the increase in cost or what service they're denying you, and send it to the steward, you know, of your union, or send it, you know, to the president of the union at your chapter. We want to collect those and bring those to the treasurer and help fight and expose how many people are being impacted here. And so that's one thing that the union is trying to do, is to kind of raise up those stories, fight those, bring those, and push collectively, and have many people share those stories. So we're not by ourselves, feeling like we have to do it all ourselves. But we want to help you to do that, so we can challenge them that this coverage isn't the same. They can't keep hiding behind that fact. But it's going to take us coming together to push them to do that.
Hey, everybody, this is Ashley again. I wanted to kind of give you a little bit of inspiration. Over the past year, working with this committee was pretty hard. We would talk to representatives on both sides, and they would tell us, oh, yeah, we got your back. Yeah, we're going to take care of you. We want to help you. Share. And then they would vote the same way they vote all the time. I got to feeling pretty helpless at some point, but I'll be honest, after hearing what's happening with this big, beautiful bill, and all the ridiculousness that is happening at our state legislature, I am more emboldened, more angry and ready to fight than ever. And if I can inspire you guys to please help us fight, because one person can't make a difference. We can't go up against these massive corporations. That's why they're bleeding us dry right now, because they know it's not going to last. Together, we can fight this, we can win, and we can get our health care back. We shouldn't be dying working at state facilities that don't protect us, that don't pay us decent salaries, that aren't giving full retirement benefits to the new people coming to work. They treat us horribly. And together, we're the only ones that can make change. They're not going to do it. And if you were present at any of the No Kings rallies recently, you feel that inspiration of togetherness. I can't begin to tell you how important it is to join with us. We've got to have your support. And thank you to every single one of you who came. And thank you to every single one of you who shares this information with just one person. Just one person. That's all we're asking. Get one person on board. We're going to win this fight.
Yeah, I think that was beautiful, Ashley. It's so powerful. We've been pushing. So having you all come to our meeting next Thursday, we also want NCAE. I know there's a number of NCAE education workers on this line. Both of our unions combined, right? UE 150 and NCAE, we can be a powerhouse if we can get our membership. The power is in the working class and us as workers uniting across the state. And so having so many of you from all these different corners of the state, putting pressure, we're going to be coordinating pressure around these demands on the legislature. But we really need your energy and enthusiasm and involvement to do that. We had 2 meetings this past week in Granville County, with the legislators there. It's the only county that our union, across the whole state, the only county that flipped from Republican to Democrat in the last election, because we organized in our communities where our members lived, and we flipped both the House and the Senate seat, right? We can do that everywhere. We can push, no matter what party they're in, to force them to listen to us. But we can't do that if we stand alone. We gotta join each other. So, see, brother, President Willie's hand is up.
Good evening, everyone. As I sat and I was listening, I learned a lot more. I understand that as many of us municipal workers as well as state, everybody is suffering from this transition. But the sad thing that has come upon me to realization of really what's happening is that we have an insurance company and an insurance provider that's created a plan for us that looks like a symbol without substance. So we have an insurance that is a symbol without substance. There's no substance behind it because it doesn't cover the things we need. So as we attack this, they're putting money in padding both of their pockets by not providing services. And those services they provide at an exorbitant rate. So here we are still doing the same thing, and they're doing things different to try to break us, to try to hurt us. So as we attack this symbol without substance, we have to understand that we have politicians that are also symbols of our districts without substance that has put this into place. It only reflects who they are. As we attack this policy, let's not forget to attack the politicians with it. As we attack this policy, we have to understand that this symbol without substance was created by a symbol that's supposed to represent us that has no substance in our favor. So as we attack it, we cannot forget those who have placed it in place. And I think we need to go after them just as hard as we go after this travesty of what we call insurance. We need to, when we hit one, we hit them all. We find out who voted what and go at them from there. Because people need to know when they begin to suffer, who caused it. I yield.
Thank you, Willie.
Why are we no longer Blue Cross Blue Shield anyway? Like, why did the state drop them to go to Aetna to begin with?
Because Aetna's cheaper.
But they're really not. They're more expensive, and then they don't even pay for half the stuff that Blue Cross Blue Shield did pay for.
You got to understand, when I say Aetna's cheaper, Aetna was cheaper for the state.
So at that point, they were more or less thinking about themselves and not their actual employees.
At every point, they're always thinking about themselves and never about us.
It's insane how you think they would think about their employees first, because we're the ones that are working the hardest while they're living it up, more or less.
You have to understand, Mr. Briner was thinking more towards the longs of saving the state money. So he has a talking point when they go to make sure he stays in that position. He saved money. He saved the state money. He saved the taxpayers' money. That's his talking point. So that keeps his job. But in essence, he cost us money. He got an extra $150 million from the state to help, offset. But he still hit us with $350 million that we have to cover. So like I said, it was cheaper for them to go with Aetna than Blue Cross Blue Shield because we're paying the difference.
Well, how about we just buy a big old ship and put all them state legislators and whatever on the boat and take them to an island and let them stay there with no money, no health care, no food, no nothing, and just let them stay there, and we take all that money and take care of our families and see how they like it.
That sounds like a revolution to me. I like her.
Any more questions? One more time. Any more questions?
Yeah, I was going to say one thing. I put a thing in the comments, but I'm with Raleigh Water, so I don't think this is affecting us as a city of Raleigh at least not yet. But to piggyback off of the last comment, if all state employees just said to hell with it and didn't come into work, you know, starting tomorrow or Monday, you know, all our road projects, all our DFT projects going on across the state, whatever other services the state that provides, if it just up and stopped, how fast do you think things would turn around? It would turn around within 24 to 48 hours. If that. And that's all I got to say.
That's an excellent idea, the start of a plan, I hear.
I don't think it
The
would
I-
change anything. There's been so many employees that's done that, and most of them lost their jobs just because they were on strike and didn't want to do anything. They'll find ins and outs. The state always does, just like the government. They always find ways to make the employees look wrong, and they end up losing their jobs because of it. That's why so many employees now, especially at my job, I'm the voice at my job, and most of anybody, I know Charles knows me. He knows I speak. I
Yes,
have a
ma'am, I do.
voice. I have a voice, and I don't mind speaking my voice. But there's so many employees out there that are terrified to join a group or to speak up because they get threatened their jobs, or, you know, go out there to want to march to do something, right? That's the number one thing. The state is always threatening. Like, you've got to walk on eggshells with the state. They're terrified of what the state can do. You're not going to find many people that are just not going to go in because they need that money to survive. And they're not going to pay you to just not go in and not work. So good luck with that one when it comes to some of the state workers.
Yeah, I know that's the same problem we have in the city of Raleigh. But, you know, it kind of all falls back on the same thing. It's like they can't fire us all. They fire us all. I mean, how many private contractors are there that are out there? And then how much is that going to cost?
Hey, Joel, let me offer something. How you doing, Joel? First of all, how you doing?
Good. I'm doing good.
All right, this is Willie. I've been there. I've been exactly where you're talking, and y'all know it. But let me share something with you. Whenever we have a situation like this, we might need to try to shop our insurance, try to make an alternative, because they're getting us under a pack. So being that we don't have any alternative, they're using that as shooting fish in the barrel. So now, as unions and stuff, as locals, if we develop or try to find insurance that we can afford, then they'll have to come to grips that they'll be losing a substantial amount of people. Just like our union has come up with some disability insurance that start paying day one instead of have to wait till you exhaust all your good time, you know, your earned time, vacation time, and so forth. If we would try to shop around and find an alternative insurance and break that group pack that they have, then they'll come to concern. It'll come to concern. Are you?
Yeah, I agree with that.
Yeah, I mean, you know, I mean, Yolanda, I mean, Joel, this is an excellent discussion. You know, I mean, we gotta really continue to engage our coworkers, right, in this fight, and encourage them around the union and what we're doing. You know, like Nikhil just put in the chat, you know, there's 18,000 DHHS workers, right? And you know, we got a couple thousand in our union, but there's a lot more we could build at Caswell, at Cherry, at Oberry, all these facilities, right? And our union has been involved in multiple strikes, right? And not a single worker got fired. Public sector strikes here in North Carolina, right? Healthcare is a little more challenging, right? There is a abandonment issue, but so, being part of the union, is we got to set up trainings about your rights, set up trainings so that people can understand what tactics we can use, what their rights are, what management can and can't do to us. We got to take steps to engage people, because the more that people see little things like petitions and flyers and people even wearing buttons on the job, wearing union hats or shirts, little things that get people, the union visible. We're not going to be able to jump straight to a strike, right? That's of course the final weapon, and only if we have to use it. We're certainly not there in DHHS, right? We got a lot of work to do. But we thought that in the sanitation workers in Durham a couple years ago when they went on strike. We think that they were ready, but enough happened that they were ready and they won, right? $28 million in raises, not a single worker fired, right? So, but we got to experience, we got to do it right. We got to be safe. We got to protect each other. We can't just jump out there when we're not ready. But we also got to make sure that we're when the iron is hot, when people are ready, we're with them. We're not holding them back, but we're there side by side, helping encourage folks, giving people's tools and resources to be able to fight back. Really excited to continue to build this union with you all and get more people involved in whatever way that they can. It might be something small, but if everyone takes a small step forward and we're all stepping forward together, we're going to win. That's the key here. We got to be moving forward. Slow but steady wins the race.
If I can jump in there with you, Dante. That's why we have this right here tonight to start, because we can't do a whole lot until we get more members in this union. For anyone that's on the call that's not in the union, why? Join. For everybody that's on the call that's in the union, talk to somebody else. Get some more folks in it. Explain to them why you're in the union. Touch base with them. Give them some out. Hey, anybody that's in the union, you got my number. If you're at Cherry, you know where I'm at. They can come talk to me.
You're not hard to find, that's for sure.
Absolutely.
I've tried at Caswell. I'm not gonna lie, especially on my unit. Like, I'm constantly bragging about how good it is to be with somebody that supports you and what you have to say. And when most people learn that you're part of the union, they don't really want to mess with you too much. And most people at my job know I have a voice, like I said. And I've spoke up with my unit, because the unit that I work on at Caswell, you have to be CNA certified to work on we call it homes, in that home, versus the rest of Caswell is mental health behaviors. My argument out there is the people that work with the mental health behaviors gets paid more, that don't have to be CNA certified, than the ones that are CNA certified and worked with more of the sick that also have mental health behaviors, but they also wear trachs and tubes,
Ma'am?
And then we got health insurance that we have to pay on top of that. So we get paid less with this high insurance. They get paid more with the differential, and they got the insurance. So tell me what sense that makes.
Well, Miss Yolanda, with those out there that ask you why join the union or whatever, you fire back at them to look back October of last year. How do you think the nurses got that wage increase? You turn around and you tell them, in February of this year, where do you think those healthcare tech increases came from? Those wage increases were a result of the battle by the union, by this union, okay? Without that fight, those increases wouldn't have happened. But we need more help to get more stuff. We need help to get the things that we need. We need help to cut out this crap with the healthcare We just need help. That's it. Plain and simple. I yield.
All right. Well, I certainly want to thank everybody for getting on this call tonight. Really appreciate it. Think it was very powerful. And at this time, this is going to conclude this presentation. So thank everybody again.
All right, thanks, Will. And
All
thank
right.
you, Yolanda. Good to meet you.
All right. Y'all
Hope
have
to
a
see you
blessed day.
soon.
Thank you.
Great work,
You too.
everyone.
Thanks. Great work, Charles. Thank y'all.
Brother William.
All right.
Bye,
Awesome.
y'all.
Good
Really
night.
powerful, everyone.
Good night.
Good job.